Lorenz. I'm one of the nurse practitioners at the Arthritis Center. I've been there for about 6 years, and I work with Dr. Mel Churchill. Tonight I picked this topic of lab studies because I get a fair number of questions about labs every time I see patients. Why do we do them? What are they for? Why do you have to stick me so many times, or not so many times each visit, but just each time I come in, why do I have to have labs? And what are you using those numbers for, basically? So that's what we're going to address tonight. I'll do just a little presentation and then open it up for questions. Okay, so just a little plug about our lab. We do have a very, very busy lab. I didn't realize that we did this many, but we do 160,000 lab tests in-house every year. So in-house, that's for the patients that we see, the labs that we actually perform on our machines in the lab. In addition to that, we do 7,000 labs that we send out to reference labs each year. So big volume there. We do have, or we perform specialized tests, rheumatologic tests. Oh, Steve! Anyway, specialized rheumatologic tests that are, hey, hang on just a second. I don't know how to fix it. I'll see if I can just click out of that. Okay, I'll just say keep the current. Oh, wonderful. Can I drag it? Here, we'll just do that. When you can't get rid of it, just move it. So anyway, we have a specialized lab. We do some tests like the antinuclear antibody panel, a bunch of other extractable nuclear antibody, or the ENA panel, rheumatoid factor, and CCP. Those are specialized rheumatologic tests that sometimes even the hospitals around here don't do, but we do them in-house to better serve our patients. Our lab has received a number of awards. They are accredited by 2 organizations, COLA, which is the Commission on Lab Accreditation, and then CLIA. I don't know what that stands for, but it is federal regulations that are even more stringent than COLA, and indicates a high quality of accuracy, safety, just a well-run lab, that we know what we're doing. Also, we received 3 years in a row, we received a Lab Excellence Award that is awarded to less than 3% of labs throughout the country, and we actually got it 3 times in a row, which is pretty remarkable. This is our lab staff. They have over 110 years of cumulative experience. 4 of them have bachelor's degrees in some sort of science, like biology, chemistry, or lab science, and have been trained in hospital labs. 2 of them are medical lab technicians who were trained at facilities like Southeast. So the 4 medical lab scientists, 2 medical lab techs, and then we have 1 certified phlebotomist, Dawn, who I guess is not in that picture, but she came from our research department. She's super. If you have a heart vein, she is the girl to see. She entirely works drawing patients' blood. So the 4 main reasons why we do lab studies: help make the diagnosis. When you come in, you have a variety of symptoms, a variety of things that have occurred in your past medical history. You're on a bunch of different medicines maybe, and we have to kind of distill from all of that information what your diagnosis is. So lab tests obviously help us to tease that out, help us to rule things in, rule things out, etc. Then once we have you diagnosed, have you on treatment, have medications, the labs can help us know how well we're doing, obviously, in addition to how you feel. And then medication safety. That's a real big one, that if we have you on certain medications, it's just safe practice that we would check your labs intermittently, and sometimes more than others. And then to make clinical decisions along the way. If your numbers aren't looking so good, you're not feeling so good, then possibly we would change therapies, kind of switch gears and try something different. These are a list of typical lab tests that we do in rheumatology. Some of them are pretty normal blood tests that are done in any kind of a clinic setting. CBC, complete blood count, the kidney studies, liver studies, and then some electrolytes. The last two are our more specific tests, the inflammation tests, and then our specialized rheumatologic tests. And I'll go through each of these a little bit. All those previous ones were tests on blood. We also do urine tests, so urinalysis or urine cultures, and then synovial fluid analysis or cultures, and that's fluid from aspirated out of a joint. We do have a number of lab panels that just makes ordering labs a little bit easier. They're kind of catered to what we're seeing you for, and each doctor has slightly different lab panels, but if you're a new patient, we would draw kind of a more extensive panel to rule in, rule out things and get a real full-fledged picture of what's going on. Then we have inflammatory arthritis panels and OA and osteoporosis. Basically, they're really catered to whatever we're treating. Sometimes we do labs in between your clinic visits to monitor safety of certain medications, and so that is helpful. I should mention that we also, I mentioned the outside labs that we do, that 7,000 outside labs that we do. If you have another doctor that you know is going to be ordering tests, is going to be wanting some blood work around the same time that you're coming in to see one of us, you can have that doctor send an order to our lab, and we will run the tests, we'll do all the paperwork, send it out if it's not something that we do, and get the results to your other doctor. That saves you a stick, it saves you a little time, all of that, probably some money. So just keep that in mind, that we can do other kinds of tests from other docs. Okay, this is getting ridiculous. I'm sorry. I might just have to give him a call. I guess I don't care, I can make it a whole bunch of minutes. Yeah, I was going to postpone for longer if I could, but there. Okay, I'm sorry. Okay. So the CBC is a reflection of your bone marrow function. The bone marrow, yay! We've been having some technical issues. So it'll pop up again, just watch. The CBC reflects your bone marrow function. That's where most of your blood cells are formed. The main types of blood cells, main cell lines are the white blood cells, the red blood cells, and the platelets. The MCV, that whole line of lab tests, those are specific tests on the red blood cells. They tell us the size, the shape, the hemoglobin content of the, when does it close at? Of the red blood cells. And yeah, I said that already. Okay. The white blood cells, of course, cells of your immune system. If you get sick, generally your white blood cell count will go up if you have an infection, but it also can go up if you have inflammation. There are different kinds of white blood cells. They have specific functions. I'll show you those in just a minute. High white count can also be caused from other things, like if you've had trauma, surgery, dehydration. Low white blood count, we watch carefully for that in our lupus patients. Obviously, bone marrow failure would cause that, and then we would send you off to a blood specialist. And then if you've had a cold or a viral infection, we often see a subsequent low white blood count. This is just a picture of the different types of white blood cells. I'm not going to go through the specifics of all of them, but it's a very complex, very incredible system that all of these work together to keep us safe from infections. Red blood cells are red, and they are a biconcave disc shape. They're very flexible, and they can kind of change shape and squeeze into even very small little arterioles all throughout our system, and they are the transporters for hemoglobin, which carries oxygen to the tissues. And I'll show you that on the next slide. But basically, if you don't have enough red blood cells, you are probably not getting enough oxygen to your tissues. That's a condition called anemia. And you might feel weak, faint, etc. And this is a picture of the hemoglobin. The oxygen molecules are the little blue balls in there. So that molecule, the hemoglobin, binds to the red blood cell. And the heme portion of hemoglobin is iron. So that's why iron and red blood cells and anemia is so closely tied together. There are different ways to classify anemias. That's kind of a whole big topic unto itself. But for our purposes tonight, basically low hemoglobin and red blood count can be caused by decreased production, increased destruction, or blood loss. So vitamin mineral deficiencies like iron, folate, B12 deficiencies, chronic inflammation like our rheumatoid arthritis, lupus patients, and then of course if you have bone marrow, chronic kidney problems can cause decreased red blood cell production because of a hormone that the kidneys make that help produce red blood cells. If they're being destroyed by something, typically you would be seeing a blood specialist. And then of course blood loss from trauma, surgery, or gastric bleeding. We do watch for that closely in our folks that are on non-steroidal anti-inflammatory drugs. That's often part of our questioning. If we see someone with anemia that's on an NSAID, how does your stomach feel? And then of course heavy menstrual cycles in menstruating women. The typical ones that we see are the anemia of chronic inflammation. Of course, we would hope that that would improve as we get better control of your inflammatory condition, and it really does. If you are anemic and the RA or whatever seems to be under fairly good control and we can't really figure out why you're anemic, we will often do these levels, the folate, vitamin B12, and iron levels to see if there's some kind of deficiency going on. Also, patients can have just an anemia of chronic disease. Again, we see that in folks with kidney issues, but also if you just have a number of chronic comorbid diseases, you can have just a normocytic, normochromic anemia. The red blood cells are pretty normal, you just have anemia. Okay, on to platelets. In this picture, the platelets are the little dots. The red blood cells are the big red ones. Platelets, of course, help to stop bleeding. When there is an injury, either in the body or on the surface of the skin, the platelets kind of run or float over to that area and make a little plug, a platelet plug that kind of helps seal it off temporarily. Then they send chemical messengers to other components of the clotting system to come in and make a more permanent blood clot over that area to stop the hemorrhage. Obviously, if you have a low platelet count, you would be predisposed to bleeding, and high platelet count, you might be more predisposed to clotting inappropriately. So there are a lot of medicines that can cause alteration in your blood counts. If you're on these medicines, we will be checking your CBC. The steroids, they cause, so corticosteroids like steroid injections or prednisone causes kind of an artificial elevation in the white blood cell. It just changes where white blood cells, changes where they sit in the blood vessel. And so when we draw the blood, we get more of them. So it's kind of an artificial elevation. But we do see that if you've been on prednisone or have had an injection, we'll see an elevated white count for a little while afterwards. Methotrexate, sulfasalazine, leflunomide, those are DMARDs, or disease-modifying drugs for RA and other rheumatologic conditions. We monitor your blood counts usually every 1 to 3 months. NSAIDs, we worry about gastritis or bleeding from the stomach, GI tract if you have low hemoglobin or red count. And then the gout medicines and some of the biologics can rarely cause problems with the blood counts. So that was our bone marrow, all the blood count issues. Now we're moving on to organ systems. The two main organs that are involved in metabolizing and excreting medicines are the kidneys and the liver. So we watch those carefully as we're giving you medications. The two main tests that we obtain regarding the kidney function are the creatinine and the glomerular filtration rate, or GFR. They are inversely related. So as the creatinine goes up, the GFR goes down. And we want that GFR to be very good. We want there to be a lot filtering through the kidney. We want the kidney to really be efficiently filtering our blood. So if we see a trend downward, usually we're asking some questions, finding out if maybe you're dehydrated. If you're on an NSAID, we might reduce the dose or get rid of it. So we watch that very carefully. You know, God just gave you two, so we don't want to hurt them. So again, the NSAIDs, some of the gout medicines can affect the kidney functions. Diuretics, because they dry you out. They're water pills. They kind of dehydrate you somewhat. Some blood pressure medicines and antibiotics also can impact kidney function. So the liver is the big organ that detoxifies our blood, helps metabolize medications and food. The ALT and AST are two liver enzymes that we check. ALT being more specific for liver injury, AST being less specific. But we look at those as a pair and we watch the trends. A lot of medications, our medications and a lot of other medications can cause alterations in the liver counts. ALK-phos, or alkaline phosphatase, is kind of a crossover lab test. It can either indicate gastrointestinal issues or skeletal issues. So bone disorders, if you have a bone metabolism disease, then the ALK-phos often will be out of whack. And then the albumin, also an important liver test. Often this is the one to change first. If we start to see that go down, we watch that very carefully and sometimes make adjustments to your medications. We don't want that trending down. That can be the first sign that there's some toxicity in the liver. And just some of the medications that we use that can affect your liver tests in a negative way. Of course, methotrexate, we're getting labs every 1 to 3 months. Leflunomide, same thing. Imuran, we use that for lupus and rheumatoid arthritis. Kind of same thing. I think we do that about every 3 months, however. The gout medicines. And then, of course, if you are drinking alcohol and you're on medications, especially medications that can be hepatotoxic or toxic to the liver, your risk of having problems with those medicines is higher. Oops. Okay, Steve, this is what we're talking about. First it was one thingy, and then now this started coming up. I postponed it, but... Oh, how'd you do that? I tried to do that. Okay, thanks. Okay, one of the electrolytes that we check is the potassium level. Most people kind of know, they kind of correlate potassium with muscle cramps. If you get a little dehydrated and you know, muscles get a little irritable, you have potentially a low potassium level. It affects a lot of different cellular functions, including the cardiac muscle. So if you have an altered potassium level, you can have cardiac arrhythmias. Some of our medicines too affect this, so we monitor it. Low potassium also can be caused by diuretics, anything that kind of dries you out, nausea, or vomiting or diarrhea, you're losing potassium. Our steroid medicines like prednisone can lower your potassium. And then the NSAIDs like ibuprofen, Aleve, Celebrex, a whole bunch of them, those can make the potassium go up, be elevated. And then if you have decreased kidney function, often the potassium will also go up. Calcium is another electrolyte, again, involved in a lot of cellular functions. We check this a lot in our folks that we're monitoring or managing their bone health. Calcium is primarily stored in the skeleton. If you don't get enough calcium, like in your daily diet or supplements, your body will, in order to keep that blood calcium level normal, the body will just steal some calcium out of the bone to keep that up. So that's why it's so important to get enough calcium in your diet. Just my little bone health plug. But anyway, we check that primarily when we are monitoring your bone health or thinking of starting you on medications for your bones. And the calcium is very closely linked with vitamin D levels, You need sufficient vitamin D in your system in order to absorb calcium from your GI tract. And then the inflammation numbers or inflammatory markers. The first is the SED rate. Most people are pretty familiar with this. Basically, it's pretty simple. If you take a tube of blood and just let it sit vertically for an hour, the blood will divide into the blood cells on the bottom, the red part, and then the serum on the top. If there's inflammation, the blood cells are heavier and they fall faster, so that line where the red thing is, or where the red division is, will be higher. And SED rate is measured in millimeters per hour, so it's measured from the bottom to the top of that red line, and if it's higher, that means there's more inflammation. Some other conditions, though, can cause that to go up besides inflammation. I'll talk about that in a minute. CRP is our other one. It is a protein that is secreted by the liver in times of inflammation, injury, trauma, etc. And it goes around and helps with our inflammatory immune response. And SED rate, again, less specific. Different things can make it go up. If you have certain blood protein issues, thyroid disorders, it naturally increases with age. So we always have to take that into account. CRP is much more specific for inflammation. Both of them together are very helpful for us as we're monitoring our inflammatory disease patients to see how you're doing overall clinically. If you're doing well and these are still elevated, then we have some work to do to figure out why. The urine tests, we do these primarily, well, based on what we're looking for with your urine test is largely based on what comorbidities you have, like hypertension, diabetes, propensity to urinary tract infections. We do look for protein. We see that sometimes in folks with hypertension or kidney problems. We watch closely for it in our lupus patients. The specific gravity just tells us how well hydrated you are. If it's high, then we want you to drink more water. We look for bacteria, white cells, nitrites. That's an indicator of infection, and often we'll do urine culture and sensitivities on those. Glucose, either you're diabetic and so you're spilling some glucose into your urine, or if you're on steroids, like high doses of prednisone, we'll often see an elevation we'll see glucose in the urine. And then if there's blood in the urine, sometimes it's just totally benign, but it can be indicative of bleeding disorders, sometimes kidney stones, bladder infections, that kind of thing. And then the fluid from joints, synovial fluid, tells us a lot of really good information. We often try to find a swollen joint and aspirate it on your first visits, and that helps with our diagnostic process. We look for white blood cells in the synovial fluid. Generally, if it's elevated, there's either inflammation or an infection. And it's kind of by degrees. If it's really, really elevated, then we do suspect that it might be an infection, so we also culture that. Red blood cells may indicate bleeding disorder, or trauma to the joint. Perhaps if you're on blood thinners, though, we'll see a little bit more blood in the synovial fluid, and that doesn't always mean a whole lot. Then crystals. Crystals are real important to find in the synovial fluid. Helps us tease out whether you have a crystalline arthritis or not. So do you have gout or pseudo-gout? Gout is monosodium urate crystals, and pseudo-gout is calcium pyrophosphate crystals. So they look a little bit different. Our lab techs know how to recognize them. They look at them under the microscope and tell us if they're in there, and it helps confirm those diagnoses or rule them out. So on to antibodies. Normal antibodies are substances that your body makes as part of our defense system. If you get a flu shot, your body learns to recognize that flu virus and develops these antibodies to recognize it if you become exposed to it, and then they launch kind of an immune response to take care of it so you don't get sick. Autoantibodies are antibodies that are targeted toward the body's own system, cells, organs, whatever. And they also launch an inflammatory response, cause destruction sometimes, and bad symptoms typically. And in rheumatology, we see and treat a lot of patients with autoantibodies. In general, like if you have rheumatoid arthritis and you have the positive antibodies, we call you a seropositive RA. If you don't have them, you're seronegative. So anyway, the rheumatoid factor and the anti-CCP antibodies are the ones for rheumatoid arthritis. Rheumatoid factor can be positive, though, in a number of other conditions, both rheumatologic and non-rheumatologic, so it's not a slam dunk. We would have to kind of tie that in with all of the other symptoms. If you just have a rheumatoid factor positivity and not the swollen joints and other symptoms of RA, we would not diagnose you as RA. Like chronic hepatitis, certain viral infections, mono, those things can sometimes make the rheumatoid factor go up. It is positive in some of the normal population, tends to increase with age, and but is largely present in folks with RA. All right, and then the anti-CCP antibodies, much more specific, about as sensitive for rheumatoid arthritis, but much more specific. Other conditions don't seem to make this go up. An interesting thing, though, about the CCP antibodies is that it can be a predictor of rheumatoid arthritis. It can be present in the blood for a while before you actually manifest symptoms and are diagnosed with rheumatoid arthritis. And then there's the anti-nuclear antibody. This is autoantibodies that are formed that attack or are targeted towards certain components of the cell nucleus. And again, just because you have a positive ANA doesn't mean you necessarily have an autoimmune disease. It is sometimes positive in just the normal population. Very strongly correlated, though, with systemic lupus and scleroderma, and then to a lesser degree rheumatoid arthritis, and then more so with Sjogren's. Then we have more specific autoantibodies. I'm not going to go into all of these, but they help us kind of, again, narrow down what your diagnosis is. If we see certain symptoms, certain autoimmune features, we'll do the autoimmune test and see if we can connect the dots that way. Often they're very, very helpful. The HLA-B27 is a test that we do in a real select group of patients. If we suspect that you have ankylosing spondylitis, reactive arthritis, spondylitis with psoriasis, or inflammatory eye disorders like iritis or uveitis, we might do this test. And it is basically an antigen that is present on the outside of the white blood cells in certain people. And if you have that, your chance of having any 4 of those conditions is greater. So it kind of also seals the deal or helps give us some additional confirmation. If we suspect that diagnosis and you have the positivity, it helps confirm. But again, it's positive in a fair number of the people in the population, 6 to 8%. And then the last one is the quantiferin gold TB test. This is one also that is pretty select, a select group that we do it in. Patients that are on biologics or are more immunosuppressant medicines, we do the TB test before we start treatment to make sure that you have not been exposed to tuberculosis. If you have been, when your immune system is rigorous and doing well off of the immunosuppressant medicines, your immune system may be just keeping that in check. When we start immunosuppressive medicines, then you could potentially come down with active TB. So we definitely want to know if you have a positive QFTB test so we can get you on some anti-TB medicines before we start our immunosuppressive medicines. We do this every 2 years also if you're staying on the biologics, which is like Remicade and Enbrel, Cimzia, Orencia, and Benlysta. So that is that. So all of you at your next office calls will be interpreting your own lab tests. No, just kidding. So I'm going to turn this off.